And we will go quick so we do not delay our lunch. And I know most of us have heard a lot about the Empower Youth pilot study, but in a little more detail. And we want to present some of our lessons learned and how we're moving forward from our pilot into an implementation phase. So Emma and I will present on that. I'll turn it over to Emma.
So just as a quick overview of our project, the goal was to design a digital training program to help address the common mental health challenges of adolescents in settings that they regularly and already access. We partnered with the Harvard Department of Psychology, so the co-PI of the project is John Wise, as well as the Baumler Institute with Kate McLaughlin and Ariel Steinberg, as well as a couple collaborators at the Children's Hospital of Philadelphia, including Jamie Young, Karen Schwartz, and Claire Heck-Bitch. So our target population of providers we identified are frontline youth workers, which we kind of broadly define as really any individual who works directly with youth in settings such as schools, communities, or primary care. So a couple examples of these obviously are teachers, staff from after school programs, etc. And then we wanted to design a brief evidence-based transdiagnostic intervention that adolescents, specifically with mood and emotional disorders and challenges, will be able to receive from these providers. And these this intervention we based on the first principles of feeling calm and solving problems. So as just a bit of context, Dr. John Wise's work involved identifying what is called these first principles. So these are principles of change, which is similar to mechanisms of change, but it involves kind of more overarching concepts instead of specific processes. So feeling calm is relaxation techniques that help decrease physiological arousal, and then solving problems is problem solving. So a structured series of steps that help youth identify their problems and then identify effective solutions. So through our formative activities, we developed the Empower Youth Intervention Protocol, which is a 2-level stepped care, progressive stepped care intervention protocol. These 2 levels we identified as most feasible for delivery by these non-specialist frontline youth workers. So the first involves what we coined the first encounter meeting. This involves establishing rapport with the youth, teaching this quick relaxation skill, quick calming, which is a technique that can be taught in like 5 to 10 minutes, and involves combining guided imagery with deep breathing, and then engaging in collaborative decision-making to end the meeting. For youth who either want or need additional support, the second level of care is ideally 1 to 2 additional meetings in which they can follow up on quick calming, but more importantly, they can also be taught the technique of problem solving. So we took and adapted a very condensed version of what is called the solve problem solving technique, which is similar to kind of overall problem solving techniques. And then, as you can see, at every stage of this, they have the option to end the intervention or refer out, as well as continue repeating the follow-up meetings if additional meetings are available. So then, building off of our intervention, we developed our training curriculum, which involves 3 main courses: the foundational skills course, first encounter, and problem solving. Do a super brief overview of these. So the foundational skills course, all of them involve 3 modules. The foundational skills course teaches youth just kind of the basics and fundamental, or certain, not youth, providers, the fundamentals of youth mental health. So this is recognizing common youth mental health challenges, delivering mental health support and person-centered care, as well as provides an overview of kind of essential provider skills. So as you can see, warmth, acceptance, etc. And then also we created a whole module on managing situations of risk. So this is both assessing and responding to risk of harm to self and others, as well as handling other types of risks such as bullying, potential instances of abuse or neglect.
Maybe I'll just show one of the videos, maybe like just the problem solving one.
And then our second course, as it follows for our intervention, is teaching that first level of care for our intervention model, so the first encounter. And then, as you can see, the modules kind of follow naturally in terms of starting the meeting, teaching quick calming, and then ending the meeting. And then finally, we have our course on teaching the condensed version of problem solving. So we provided kind of an introduction to the technique and why it's relevant for youth. We had a whole module on teaching each of the 5 steps of solve, which, as you can see, involve the various steps of the structured approach, and then following up on solve, as well as we included a bit of content on how to adapt teaching this technique to various time and meeting constraints. And here is an example of one of the videos that we produced.
People here on Zoom? I think it's sounds coming out of my computer.
At the moment, I can't hear anything.
Welcome to our course
Now I
on
can.
problem.
Yes. We can hear it.
My name is Mrs. Sarah,
And my name is Mr. Marco.
and in this first module, we will get an introduction to the procedure of problem solving and how it can be used to provide mental health support to young people.
So let's get into it.
Problem solving is a term used often in everyday conversation. However, in this course, we will go over a specific way to do problem solving that has been shown to be effective in helping young people manage their problems or their reactions to problems.
I'll just stop there for the sake of time, but as you can see, we have some didactic video content as we normally do for the Empower videos, and that's complemented by a lot of role play videos as well.
So as Laura just mentioned, the core content is delivered via videos. We then also developed a bunch of interactive kind of activities and content that surrounds these videos, specifically with the idea to accommodate various diverse learning styles, because I know personally for myself, auditory learning is not one of my strengths. So that was great. We also built a whole kind of library of additional learning resources for individuals who wanted to expand beyond the level of detail or focus that we provided in our videos. And then we also developed a bunch of supplemental training materials to help kind of support the learning process. So we have note sheets, we developed a digital manual, glossaries, and then a bunch of clinical worksheets and handouts that providers can directly provide to youth. So if you even want to just click the first of these, this is just a little overview of, and then do you want to expand it just so you can see it a little bit?
Show this one.
These are just little overviews of what the course, the final course looks like. Sorry for the horrible quality. It's probably for the size of the little
Yeah.
video box. But anyway,
Emma did a really good job building out the below the video content. So it's very engaging. So people can do matching games, there's flashcards. So it's all reinforcing what was taught in the videos, but we got very positive feedback on that in our pilot study that they felt like they understood the video and then they realized they actually don't know all the main terms, or it's just like a fun way to engage rather than just sitting there and passively tuning out instead of just watching videos nonstop. So I'll talk a little bit about how we did our pilot study. So the aim was here to evaluate just the feasibility and acceptability of our curriculum. No one was delivering this with youth yet, didn't have the funds to do that, and that would be our next phase. We also included some questions about how providers thought that this could work with youth in the communities that they saw. We used convenience sampling and we recruited through the Balmer Institute. The Balmer Institute, for those of you who don't know, Emma mentioned them as one of our partners in the formative research phase. They're essentially in the state of Oregon creating a new child behavioral health workforce at the bachelor's level. So there's a lot of people that have come to the micro-credential program that they have. They're throughout the state of Oregon, and that has just been a 3-course graduate program, mostly for teachers focused on child behavioral health. So we recruited from that. And then also many of us are familiar with the work that the Congregational Collective is doing in San Antonio through a contact that we had there, Veron. Some of her volunteer work is working with affiliates of Davis Middle School. They have an after-school program with youth. They know the teachers very well there. This is in a lower income area of the San Antonio city. And we also recruited them to test our curriculum. We use many of the same measures that we always do for Empower. I'm just going to highlight a few things that were different or unique here. So we created knowledge assessment. This was very similar to how we didn't use the same process as we did for BA because we didn't have the time, but it was still the same format. A vignette-based multiple choice exam. I think Caitlin did something really fascinating on Qualtrics that she's mentioned before. So we were able to randomize it. So everybody got a different version of the pre-knowledge assessment and a different version of the post-knowledge assessment. So within Qualtrics, there's a function that it will, especially if you're using the same email address, it can know which 19 questions you got asked first and they'll give you the other 19. So no one had the same pre and post test. And that helped us randomize our net measures very well rather than creating 5 different versions of it. We also used for the first time an asynchronous role play based assessment for competency assessment. So we had consultants in the fall that were developing this. What was different about it and challenging about it is that with the asynchronous format, there's no back and forth that a provider can have with the pretend youth. But also what we were, I guess, anticipating would be helpful about the asynchronous version is you would not need a live actor. So we had team members on our own create videos pretending to be youth. It was like a 30-second clip. And Emma provided a lot of instructions that were written as well about the learning objectives. And then we had participants record themselves to respond to the prompts. So this was a little bit challenging and we'll share some of our findings around this, but that was something that we were aiming to test for this pilot study. And we had various questions in a survey about feasibility and acceptability. We also conducted focus group discussions at the end to gain additional insights into feasibility and acceptability of the curriculum. Well, very briefly, I'll go through our participant demographics. It was pretty evenly split between affiliates of the Balmer Institute and folks that were in San Antonio, Texas, mostly female, mostly, I guess this age range is not surprising at all, mostly working professionals. We had, for race and ethnicity, not nationally representative, it's not supposed to be, it's a small sample, but the site that we had in San Antonio, Texas was mostly Veron's group and very focused on supporting youth that are Black and African American in San Antonio. Most people did have a master's degree, and it was largely, even though we had a bit of diversity with current role with youth, most people were teachers or paraprofessionals or special education teachers, so some kind of teaching role in the school, which was great because the big funding from the Manton Foundation, that is where we originally intended that Empower Youth would be most useful. So most of the feedback we were able to get was from people that were in teaching roles themselves and a lot of experience working with youth as well. So our results are, we learned that our knowledge assessment was too easy, to put it simply. Everybody did very well. So you can see in our pre-test, people are already getting almost at 80%. We did not see much of a change at all in terms of even descriptive statistics. Our t-test is not significant. Once again, this is a really small sample of people, but this showed us that even 7 of the 19 questions in the pre-test where people hadn't been exposed to the curriculum yet, they're already getting them right. So we flagged that and we know we need to go back and do more work in the next iteration before we move on to implementation of revising our knowledge assessment. We do want it to be useful. So our hypothesis is that the measure was too easy and also that a lot of folks came in and because they were working with youth already, they may have had some knowledge already about what would be helpful for youth. Our dissemination implementation questionnaire revealed that the curriculum was largely feasible and acceptable and also usable in terms of the system usability scale. We use the IAM, FIM, and the system usability scale, which we use for the BA pilot as well. And we are in the process of completing the competency assessment rating. So we don't have findings on this yet, but a process that we will do is use the equipped tools to rate all of the videos that have been turned in by participants. Emma and Fajar here will be doing the rating supported by someone from John Wise's lab, who is a clinician who has worked with youth. So she will support them, will establish inter-rater reliability, and we have a lot of videos. I think, Emma, you did the organizing of videos, but each of the asynchronous assessment required them to respond to 10 different prompts. So these were short responses. Not everybody did all of it, but it's a lot of videos to weed through. So there's quite a bit to be rated. We might not do all of the ratings. We may go until saturation is reached. And then we conducted 5 focus group discussions. We ended recruitment once people were no longer signing up, but I thought this was a pretty good number for having only 50 people in the pilot study. And we are currently analyzing the data and we'll have that ready. We already have some preliminary findings that we can show you. So we had pretty good representation across both of our pilot study sites and they largely represented the sample. And Emma will share some of the feedback we received.
So you can obviously read all the little blurbs that I pulled, but a couple specific ones to note is that participants did like the additional interactive kind of activities that we added, which was a little different, as we mentioned, from the BA training. They also enjoyed the large number of additional learning resources we provided. And then similar to kind of all of the Empower Youth models, they liked that it was online, self-paced, practical videos. And then they mentioned just in terms of what the training was on, that it helped them in terms of handling situations and talking with their kids, as well as providing them with very specific, easy to use tools. And then a couple of suggestions for improvement that I pulled is that some of them mentioned that the videos were cheesy, which is valid. One of our pilot study limitations is that we had to wait until the end to disseminate the online survey, which involved the post knowledge assessment and the competency assessment to all participants, instead of being able to deliver them or to provide the online survey kind of on an individual basis after each participant finished the training. So as one said, there was a big gap in between when they finished the training and took the assessments. There was some mention of coaching, a couple suggestions around adapting or adding aspects of the curriculum geared towards different kind of settings. So group settings with youth, or non-office based kind of more informal meeting areas.
And I'll add too, I think because so many people were teachers that were in our sample, they were saying, this is great, but how are we ever gonna have time along with the youth? Our days so busy. And so part of it is for us interpreting this in light of who was in our study and thinking, okay, if it's going to be delivered, what's a feasible way to deliver it? And it's probably not training teachers.
And then competency assessment, as has been mentioned, was a big area that we wanted feedback on. So we did get some positive feedback in that the competency assessment prompts did feel relevant and connected to the training. However, as you can see, the kind of mental burden of the individuals having to complete this assessment was large. So they were not prepared for how long it took. We got feedback that it took like up to 6 hours for some older individuals who are not as tech savvy to unfortunately complete this assessment.
And it was hard because we couldn't do it in Qualtrics. So Qualtrics and RedCap won't let you upload that many videos.
Yeah.
So they had to do it separately by uploading, like taking it on their phone or computer. And that was where a lot of the tech issues came in. Even though Emma did offer to meet with them and just record them over Zoom, even that they found challenging.
Yeah, there was a lot of, we tried to prevent the confusion, but we could not avoid a significant amount of confusion that occurred. We did get some interesting areas of feedback such that they would have liked actually the competency assessment role plays and responses. They felt that it would have been helpful had they come after each individual section of the training instead of kind of a post-training assessment measure. And then as you can see, awkwardness and difficulties uploading videos.
And also because this was a pilot study, we're just trying to test all of our measures in this format. I think what was different about the way we timed it compared to what we normally do in an Empower implementation is they're taking the competency assessment after completing the training only. Where normally somebody would take a competency assessment after 3 months of this practice-based learning they can have, where they're engaging regularly with their supervisors, when they're sitting in on cases. So a lot of people that said, I didn't feel like I was ready to do this. We were not surprised by that because we were giving it to them in an earlier phase, but it was really good to know about all of the tech difficulties. And actually even on our end, it was extremely arduous. Like Emma spent a long time having to make sense of all the videos and like who uploaded what, and they labeled them all wrong, and what does what video respond to what prompt. So it did reduce some barriers, but I would say it created others, potentially more.
And then just a couple areas of feedback in terms of implementation. So as Laura mentioned, you can see here, there was a teacher who essentially said that implementing the Empower Youth intervention protocol, so the 2 steps of care, would not be feasible in terms of their role as a teacher, given that they just teach to entire class and they don't have really those one-on-one interactions. However, we did get other positive statements or areas of feedback, such that a school counselor said that they did think that this was a tool they'd be able to integrate into their existing delivery of care, which is great because we initially were concerned that existing providers may not see this as relevant, given their existing knowledge. And then we got broad areas of feedback in terms of the 2 skills that we incorporated into our intervention of quick calming and problem solving being very useful and applicable to individuals who work with children, even not as a specialist. And then one individual actually said that they use the problem solving skill with their own child, which was also another area of implementation that was positive. So. And then just overall lessons learned, kind of that differ from previous Empower projects is that we did, as Laura's mentioned, identify that although synchronous live competency assessments do involve barriers, we found that our version of the asynchronous competency assessment was really not a very feasible or acceptable alternative for our provider population. Our knowledge assessment measure, unfortunately, is a bit too easy and will need revision for future implementation. And then our intervention and training was considered desirable for these providers and their use of it with young people in their communities. However, we're going to have to do further work in terms of implementation planning to make sure that our provider population is one that will be able to feasibly deliver this intervention in their role with youth, specifically having that time and one-on-one ability to meet with young people. And then finally, the additional interactive content in the training interface was good and people enjoyed those activities.
Now we are finishing writing of all of our results. And the next year is going to focus on planning for implementation. So we're very lucky that our funder has at least verbally promised to follow up. And not only with a small amount of funds, we can consider like a 3-year implementation study. So this would be at scale of what we're already doing throughout Texas for behavioral activation. And we need to think about how to make it work. So we will be making some revisions over the next year to our knowledge assessment, our competency assessment, so that this will work better as we use it in implementation. And we hope to be meeting a lot with our partners down in Texas. We're also having conversations with a connection from our advisory board group here in Massachusetts who works with school counselors throughout Massachusetts schools. So we're trying to think about what implementation will look like. And the questions that we're asking at this phase are, who is the workforce? As Emma mentioned, it probably should not be teachers. I think it has the most possibility for success in areas like the after school program that Veron runs and the Congregational Collective. So she has a group of people mostly affiliated with her church that are meeting with youth after school. They do a lot of mentorship already, so they have that one-on-one capacity and trying to think about who their supervisors can be. So where is their link to referrals? Who's the right specialist provider to come in and to support the work that we have going on? But we're really lucky to have good partners potentially in Massachusetts and in San Antonio that are excited about this and interested in it. And now just figuring out the details and how to make something work really well will be our next step. And we wanted to share a video that was shared with us.
This training has been amazing and empowering because it allows me to take these tools and to use them in my classroom.
This training actually resonated so profoundly with me because I could see even my staff, my peer recovery coaches using this because I feel like what is taught in this training is like a gift that we give to youth. What I loved about it the most is it teaches children how to problem solve for themselves when they're having some type of issue in their own home life, at school, with their parents, just whatever issues they have, you can use this tool.
What I got personally was a lot of tools and information to be able to help meet the need of the youth. As a teacher, it's not unusual that you get a student come to you and have some kind of difficulty either at home or at school.
I got from the training the opportunity to use skills that I naturally possess, but actually put a name and a method to it. I love the program because the SOLVE method is just like using solution-focused therapy, but I think it makes it a little easier for someone that's not an actual counselor.
I learned how to help children practically to calm themselves and to problem solve. I would recommend this program to everybody who deals with children.
As somebody who is breaking cycles in my own family, It was a very powerful tool in helping to educate me in the correct steps to help youth within my church program and to also help my own children in educating them on mental health.
It's reinforcing knowledge that I've had before, and it's just solidifying the proper way to handle students in crisis.
But the benefits from the program, from the training, has helped me tremendously in understanding the youth, how to reach them, how to sit and talk with them. So I would recommend to any pastor, any leader in the community that wants to reach the children, reach them at their core, get involved in the program. I guarantee you won't lose anything.
We are being transformed because transformed people transform their families and their churches and their communities. And that's exactly what we're about to do with this education, this training that we've just taken with Empower. We hope to continue this for a longer period of time because there's so many people in my community that can use this sort of education for the betterment of our children and our youth in our community. So thank you guys so much for the hard work. Emma, thank you for being an exceptional partner with this. Your work and your labor is not in vain. So keep on doing a great job. And John, as always, thank you for your work with the collective and for our partnership. And I look forward to working with you guys in many, many, many more training opportunities in our community.
All right. Thank you. We'll take any questions. How much time do we have, Kate?
Maybe just to,
Yeah.
we didn't ask them to make that movie.
Yeah.
Veron just made it, but we didn't say, we didn't commission it. So, just so you know, this was not like an advertisement video we commissioned, they made it on their own.
I think the program was so successful and is so desired for so many reasons. Like there's such a strong foundation already because of the work that John started with the Congregational Collective. So they're so bought in, they're like eager and they want this, they go out of their way to make it happen. And Veron being like such a good partner and bringing people together in the community, finding people who are interested in it. Emma did such a good job like making the training so engaging to everybody. And the Just Empower process has been working. So
Yeah,
we're very excited.
made the,
Oh, wow.
he's pretty tech savvy, her son made the video.
Like the drone shot.
Yeah, he did a nice job, yeah.
Julia says, what a beautiful and inspiring video.
It is, yeah.
I had a question about the sex differences that you saw in the pilot. Do you know why is it so?
I think there's just a lot of women in like community programs and that are teachers. Yeah, I know Emma, you've recently worked in schools, but.
Yeah, I think, I don't say this with like actual, but I can imagine that, there's still like a much higher density of like, individuals working in schools still than of female individuals working in schools.
Is
than
there a
men's.
way to reach like the male sort of population?
So I think we saw that different groups had different like densities or like gender distribution. So like the after school programs of like boys and girls clubs, YMCAs, I think there's a little bit more of an equal distribution in providers. But I think ultimately too, we're trying to target just the individuals working in those roles who do have access to the youth, regardless of kind of unfortunately what their gender is.
Just to comment on that, one thing that's very interesting is we definitely have a higher proportion of men through the faith communities.
Yeah.
Which is really interesting, and they do a lot of work with youth, so I think that might be just sort of if you're trying to get more balance, but it's actually quite striking. Many of the I'm thinking of the navigators have been men, and then many of the people who've done that training, and then many of the people who have been in other meetings working in the churches.
Yeah, I think it depends on where we implement it, and we probably, and we're considering school option in Massachusetts, but I think it will probably work best in not a school setting, like a school related setting, in which case then it's easier to find more of a mixed gender group. And it's true that, you know, adolescents, they might relate more to someone of the same gender. So if they're talking through their problems, it could be best to have like somebody that looks like them, matches them, has their same experiences, and Veron's group, I think, is more representative of people that they're serving.
Well, they run a ton of youth programs.
Yeah.
She has a whole, I visited her church, and they have like all this games rooms and all this stuff. And I think they have pretty good engagement of both boys and girls in these programs, but in terms of the staff and the church, it's pretty equally distributed, I think, in terms of gender.
And to that point, I think the lack of like male mental health specialists in schools is kind of across the board an
Yeah.
issue. So.
Yeah, Shireen?
This program was a self-paced learning program, right? So how much time, how much average time they took?
We gave them 2 months. We didn't need to give them 2 months. We think it takes them about 5 to 10 hours to go through the training.
A little hot,
Yeah.
like 10,
Okay.
10 to 12.
In 10, 12 days, they've completed the program.
So the bare minimum, just watching the videos, I think it was like 7, it was either 5 or 7 hours. If they did nothing else except watch all of the videos. And then we added on if they were doing the additional activities, like readings.
And we saw that the reasons that people dropped out were not because it was too long, it was just because they're really busy. Like they get home from teaching, they have a family, it's trying to find the time. But most people finished it. We had 33 people finished it.
No,
Or 33
the
people
training
took the
program
assessment.
completion was much better.
Actually,
I
everyone
think
but
it was-
2 people finished it, right?
I wanna say it was like, I think it might have been like 47. or
Yeah, it was
52.
really high.
Yeah. And then I know there's some online, I think, I think the reporting of the findings needs to show that. I almost wonder if this is more on the actual outcomes and evaluation. I wonder if you might wanna just get rid of that knowledge assessment, and just do away with it and actually just report the completion rates and the time it took, because I think that was my main question, is I was worried that only 33 of the 52 completed. Which would not be very good, because you're missing almost 20 people. I think it'd be better to show that 47 out of 52 completed, it took them this much time, and then here's their feedback, and use the qualitative feedback, which I think actually is much more validating and useful.
It's a good read.
Yeah, and now that I see people online, I think Julia and then Vikram.
Actually, Bikram was first, so go ahead, Bikram.
No, go on, Julia.
Okay, it's actually related to it was related to this point actually on reporting of outcomes, because one of the things that I saw that the knowledge assessment that was also it was too easy. The other thing that I saw is on this AIM, FIM, these feasibility and acceptability measures. You also, I mean, I've used those measures before, and I also find them that you always get very high averages. I don't know if you got a lot of like what the variability was there, but I also find them not so useful in basically understanding whether actually a tool is useful or not. So I wonder whether, you're planning on investigating that more. I'm assuming that you have more qualitative evidence to back that up. And then I guess it was related with what John was just saying. So another thing that it would be interesting to see is, when do people drop out of the treatment? At what point, like how often do they go into the treatment, and when is it that they drop out? And I think digging a little bit more around why is it that would be also very helpful to know.
Yeah, we agree with the ceiling effects, I guess, on the FAM. And we knew that going in, but it was such a validated tool that we thought, let's just put it in because it'll take a second. But then we asked a lot of the same questions that we asked in focus groups in the survey too. So we had a lot of open-ended questions in the survey, asking about feasibility and acceptability with the knowledge that not everybody would do a focus group. So that was really helpful too. So as we're doing thematic content analysis, I know I'm like looking there, but you're probably here. But we wanted to get the data on feasibility and acceptability. And so having open-ended questions in the survey was really great. And we'll analyze it alongside all of our qualitative findings too. That was way more helpful. We'll report the quantitative measures because we have them. We want to have something that was a pre-validated measure, but it's most helpful, our focus group data and the open-ended survey questions about what they liked, what they didn't like, what they want to see improved.
That's great. And just as a small question, is the idea that the treatment providers will be paid to provide this treatment?
Yeah, that's how we normally done it for the Congregational Collective and other projects in Texas. It's very time consuming, and we paid them actually here to take the training.
Okay,
so
good,
they were paid to do the assessments, but most of the funds actually came from completing the training with the knowledge that like they're taking time out of the day to do that. And that's the model we've seen be successful actually. And it's really doesn't work if people aren't paid because it's so time consuming.
And even if it's usually a modest amount, but people are taking time out of their busy schedules. Yeah, it's tough.
Mm-hmm. Yeah, makes sense. Thank you, and great work.
Thank you.
Thank you, Vikram.
So I just wanted to, I'd say, John, that's a really important point, suggestion you made about, not really presenting the knowledge scores. I actually think there might be two explanations for that ceiling effect. One is that the measure itself is very simple, which it is, because I mean, many of the skills we're talking about here are very intuitive. But I think that then interacts with the fact that this sample is not completely naive, in the sense that maybe 2/3 of these are teachers, and teaching curricula these days actually include teaching on basic social and emotional skills, and that typically always includes some kind of quick calming as well as problem solving techniques. So I wouldn't be surprised if it's both, that the measure is simple, but it can't be made difficult, because to be quite honest, these skills are very simple. They're very intuitive. But on top of that, I think also the kind of sample that we had is not truly naive. They're not picking up the street, as it were. They're actually working with children. And you learn these things no matter what your professional background is. You learn these intuitive skills. The question I had, as some of you know in the lab, and Laura is involved with a lot of this, we're really exploring. I mean, just to step back, Empower is really about scaling up rapidly these evidence-based psychosocial interventions. And we adopted the video-based learning as a kind of a tool to do away with the need of an expert in the room and having people come into a classroom, etc. And what we're seeing with all our experiences is a lot of acceptability, although some people do wish for some hybrid. So I don't think hybrid is excluded. And I think certainly as we look ahead, we should really not be dogmatic. It's clearly, we are not, but I think we should make it clear to implementers that the video material is really for the didactic self-learning, but you can always have hybrid, either online or like synchronous online or in person, flipped classroom kind of learning. But the real challenge that we found is the role play bits to actually, or the internship phase when people practice, as well as the assessment of competency. And I just wondered, to what extent, Laura, the conversations we're having right now of using large language model, could actually mean that a lot of what we're doing right now is going to look very different a year from now, in the sense that we deploy those kind of models to act as avatar of patients, so you can practice, but also to assess competencies and quality of therapy. Just wanted to hear your comments on that.
Yeah, even the timing, if the Google funds were to come through, the timing of it is we would have actually a product that we could use by the time we're getting into deeper implementation for Empower Youth, because we won't start implementing for Empower Youth for another year. And we already will be a year into the Google proposal at that point too. So there's an opportunity to maybe use it for the first time in Empower Youth if we can get the timing right on that. And I think what we're doing now is just trying to figure out what is the best case while we wait, and assuming that in the long term that there will be AI solutions for assessing competency, and also supplementing the training phase with AI-based role plays in the chatbot or in other tools as well. So yeah, I think that's the best way to remove all the barriers. And so we're working towards that. And it's probably not a huge use, and not a very good use of our time to spend years and years developing a knowledge assessment or a competency assessment that we think will probably be replaced soon by something better that we're working on. Other questions? Okay, thank you, everyone. Thank you.